Welcome to Healthbeat, BKCSA's monthly television show, where we check the pulse of our healthcare system. I'm Mia Malan. South Africa's controversial National Health Insurance Scheme aims to give everyone access to the same healthcare services. But for many of the about 10 million South Africans on medical aid, it evokes fear because they assume that state hospitals aren't up to looking after them. For more than 80% of South Africans, public healthcare is all there is. And sometimes it works, and it works well. The Healthcare team visited a community practice in Soweto that could serve as a model for our NHI.
Three days a week at 8 a.m. sharp, members of a walking club in Shawelo's Ward 11 pile into Masichaba Dog's home. Her garage, their gym.
I am 68 years, but I can do everything. There's a 74 here, 79, and also 94 years. And we do the same. There's no, that one is 80, you cannot do, If we say up, they do up. If we say down, they do down.
Getting fit and staying healthy in this community was inspired by Wits University family physician, Professor Shabir Moosa.
Many of us here, we've got chronic disease, high blood, and so on. And then Dr. Moosa said, guys, why can't you start a gym so that you can help the medication to work?
The idea is to prevent and manage illness through exercise and regular visits from community health workers based in the same building as the local clinic. It's called the Shawelo Community Practice, or CCP.
Essentially, we said from here, we are going to pretend and create a practice of NHI for this community. But we told everybody, 2014, don't bother to go to the clinic, the CHC that's around us. The NHI is here already. Come here, you are now allocated to us.
You can check here, that's my name here. This is the street where I'm working to. It's Luanami Street.
Community health workers like Thandi Kunene went from door to door assessing every household. 30,000 people in all.
I was the bridge between healthcare and the patient also. We did build that relationship with them.
Residents' health information was returned to the CCP for filing.
We're using the blue file for individual. Then if somebody else come again in that house, we just check to say, oh, Ayanda is here. Then we open her file again. Then there's the orange file. This is we're calling a family folder. This is only for me and the doctor. Then I know when I open the file, I know, oh, I have to go in this address to do this, maybe to talk with that patient about smoking, or maybe she's not adhering on the treatment.
Patients get appointments.
Say, I want to come to the clinic on such a day, you book your day, and then you come to on your own time, not to wake up early.
At Shawelo at the moment, doctors are paid a monthly salary by government. In the private sector, they are paid for each service provided. Under the NHI, it will work differently. A GP who contracts with the NHI will be paid a capitation rate. That's an annual fee paid monthly in advance. For this, they need to keep the patient healthy by providing certain services. The Shawelo project shows how to limit patient visits by focusing on prevention so fewer people get ill. But residents who serve on a committee to support the clinic say the CCP, which started strong, is battling.
It was very neat by then when they opened it, and it was very organized. If they can communicate like before, everything will go back.
When then Health MEC Qedani Mahlangu visited in 2015 and saw happy patients and community health workers, she told the CCP to cover more people, but without adding staff. Now the practice is at a crossroads. The hope is that the NHI could see this community model adopted and learn from it. But is it affordable? And does the government have the ability to roll out such a detailed system?
With me in the studio is the brain behind the Shawelo community practice, Professor Shabir Moosa from Wits University. Prof, why did you start the project and when?
We started this project in 2014. Essentially, it was about testing out the idea of how do you build a practice that GPs can engage with. Remember that the NHI all the way in 2007 talked about the NHI being created to not only contract differently with public service clinics, but also bring GPs and other private providers into the public service by contracting with them, using a system called capitation, where people enroll into a practice saying, listen, I want to belong to that doctor, and then cared for by that doctor or team. So I did some research around it with GPs across the country. We asked them what their costs would be and how would they engage with it. They turned out to have literally R1 more per person per month in terms of their costs to charge the Department of Health or NHI for their service in that survey, which is remarkable, R1 more than the public service was costing. And what we found is that with that system, given their current practice, that they would earn 30% more. The payment is actually creating the right incentive. I need to prevent. And that's a very critical cost driver, because the fewer people I see in the clinic and the healthier they are, the more I save money, which means that I'm getting a fixed amount to be looking after people. The healthier I keep them, the happier I am. The primary prevention is about Mr. Dlamini is not sick, but he is overweight. That is a risk. He hasn't got diabetes or obesity yet, but he's at risk. So we need to educate him, and that's what we do, both in the clinic but also in the community. And a lot of the times, because we are dealing with patients, we try and link them up with the community health worker to say, Tandi, we'll visit you at your home to do this much more extensively, but please, you need to think about your diet.
How many daily visits do your community health workers do?
They're doing what the public service is doing, which is 6 visits per community health worker, but it's nowhere near the kind of quality that I expect, and I think is what's possible in the future.
If the NHI is going to be rolled out with community health workers who only do 6 visits a day and who are not necessarily trained all in the same way, how do we get around that?
Instead of making community health workers employed by the state, the contracted party, a private provider, needs to manage the community health workers and then pay what they need to achieve the outcomes.
So what are the lessons that the NHI can learn from Shawelo? Because Shawelo is also going to be an area in which the NHI is initially, at least the primary health contracting units will be tried out there very soon, I believe.
The value is that because of the CCP work, we've got a huge engagement with the private providers as well as with the community. So that's a very useful platform, and we've got a ready-made example. So I've got lots of time and experience in that place, so it's been helpful. But in terms of the NHI readiness, there is simply to get the public service ready by having all their clinics up to scratch, which is a big question, whether that scratch means anything. The second one is the question of the health patient registry system, which is data that's collected of the population as they walk in and then as they use the service. And that's something that the National Department of Health wants as a spine to the entire system. And in the public service, they're struggling with internet and computers, etc., and usage of that system. So we've said you need to get that right. And that means that every patient, every person, every user in the language of the NHI Act has got a number, and that number is linked to the Department of Home Affairs so that their fingerprint is essentially their medical aid card.
And a very legitimate fear of many South Africans about the NHI is it will cost an enormous amount of money to implement, to have quality health services. What's your opinion on that?
That's actually one of the things we've tried to do is, well, what is the cost of this whole exercise? We found that we, in fact, have been able to reduce the visit rate. And we, in that survey, asked the community, how much do you think the community health worker has affected your visit rate, up or down? Almost half said that the way we worked reduced their visits.
But you still have funding problems.
Well, I have funding problems largely because the public service itself functions in this way where nobody really has the money. It's all higher up. And those higher ups seem not to think that's important, that this project doesn't mean. In fact, in the district of Johannesburg, I don't know of any manager except one in the sub-district that's visited the place after 10 years. I, at the moment, have tried to, using the budgets available to me, to try and get a simple thing like filing to support that place, and it's just impossibility because systems in the public service are just so bureaucratized, that it's just so impossible to get simple things.
If it's difficult to get a file in the public system, do you think it's ready for the NHI?
Well, as I say, remember the NHI is not just about the public service. So to me, the public service is going to have to play catch up. And that's the idea. Remember, what drives the world is money. And that's what the NHI is. It's a financing system to change the way money drives health delivery, health service. It's saying, principally, that we're going to take money, put it together in one pool. And from there, we're going to risk adjust for all the population of South Africa. It's about saying a budget is attached to every person. You, me, everyone in this country has a budget. When I walk into that clinic, that person knows that I've got a little, dollar sign in my head, and if they don't look after me, I'm going to walk elsewhere. And that's the strategicness of it. And remember that all I need is my fingerprint, no other complication, go to an enrolled provider. He then puts me on a system that is linked up DHA to confirm. Then NHI pays me in my account, and I see the money, and I have to see the patients. I have to make people healthier. I can deny care, but if they've got a hotline, they can complain, and I can lose the patient. So I might as well do what needs to be done, keep you healthy.
Shabir Moosa, thanks very much for sharing your time and insights.
Thank you.
After the break, a heart patient about the care he received at a government hospital.
For me to walk out of there 6 days later, it was just a miracle in my eyes,
You're watching Healthbeat, and we're looking at what it takes to provide quality healthcare to all South Africans. We mostly hear about poor governance and corruption at state hospitals and clinics, and little else. Earlier this month, a patient at Helen Joseph Hospital in Joburg released a video showing less than ideal conditions, with allegations of uncaring staff.
I'm going to tell you about my experience. And I'm going to show you what goes on inside this hospital. And I'm going to tell you about the atrocious doctors that operate inside this hospital. What do you think it works?
But there are positive stories too.
Trolls and stuff. Yeah.
In the Joburg suburb of West Dean, Ruth van der Vint is rushing through her weekend catering orders. Her partner, Angus van Wyk, is standing by to do deliveries. It's something he didn't think he'd ever manage after what happened to him 2 years ago.
I went for a walk with the dog, right? And then I was suddenly in a lot of pain. And walking back, I nearly couldn't make it home, It was something like somebody sitting on my chest.
His local clinic sent him to nearby Helen Joseph Hospital. There he had an ECG, or electrocardiogram, to test his heartbeat. It was serious.
And then they said that actually I'm having a heart attack as we speak, because they showed me on the screen that is a heart attack. So they rushed me through to resuscitation.
Angus didn't have medical aid, so he was taken to the specialist heart unit at Charlotte Maxeke Johannesburg Academic Hospital.
I thought to myself, this is crazy, 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 crazy.
Angus and Ruth didn't know what to expect from a government hospital at the center of past problems. Beds without sheets and blankets, and psychiatric patients housed in deplorable conditions are just some of the issues that have been reported on. But the heart unit seemed different, at least at the time of Angus's admission.
I was quite surprised by the nice facility that they had. But then I learned it was brand new because they had this fire there and everything was brand spanking new, you know, and I felt very good, actually taken care of. They found out that I had blocked arteries, you know, 3 blocked arteries, and they suggested that, you know, the best way forward was for an operation.
Angus needed a triple bypass. Surgeons would have to create a new path for blood to flow to his heart because of a blockage.
I was quite devastated. Obviously, I thought, you know, this can be life-threatening.
But 6 months later, surgeons at Charlotte Maxeke took a healthy blood vessel from Angus's leg to redirect blood around the blocked area in his chest.
There's some very clever people here. These guys are from Wits, you know, and I mean, that's how I looked at it, and I thought, you know, I'll take my chances here.
Throughout all the visits, whatever questions we had, nobody just brushed us aside. Those doctors, they took their time to explain.
Angus has never looked back.
For me to walk out of there 6 days later, it was just a miracle in my eyes, you know.
Guess what? The entire operation cost us 2,123 rand based on his age and the fact that he doesn't have an income, and we're paying it off.
One of the doctors who treated Angus van Wyk is Dr. Tumi Tianyani, who is the head of cardiothoracic surgery at Charlotte Maxeke Academic Hospital in Johannesburg. Our team spoke to him.
This is an operation that routinely it's carried out. Our center carries in excess of about 10 a month. We offer certain services here at Charlotte Maxeke. One of them is putting the heart valves via small incisions. When you look at the private sector itself, yes, very few centers are doing that.
After the break, what can the NHI learn from the rollout of our HIV treatment program? You're watching our September edition of Healthbeat, and we're looking at what will make universal healthcare work, apart from money. Not far from Coffee Bay on the Wild Coast lies Zitulele Hospital. Zitulele means silence, and it was at this hospital that a group of dedicated doctors, led by Ben Gaunt, quietly got on with it, creating a top-class facility that truly served the community. It showed how having invested doctors could change a hospital's performance. But 2 years ago, things started falling apart. A new CEO led to the departure of most of the medical team. Today, Zitulele has only 8 doctors, down from 17 in 2020. In the 2 years since Gaunt left the hospital, women giving birth at Zitulele dropped by almost half, indicating that they'd rather take their chances elsewhere. Joining me online to find out what went wrong at Zitulele Hospital and what kind of managers we need in rural hospitals is Primary Healthcare Professor Steve Reed from UCT. Steve, until 2 years ago, Zitulele Hospital was a centre of excellence in a really rural Eastern Cape area. Then a new CEO came in and things changed. What went wrong?
The leadership style was excessively prescriptive and didn't allow the medical team to actually fulfill their potential. So there's something generic in the issues of leadership and what sort of leaders get appointed. A good leader really brings out the potential of all their employees by not just encouraging, but creating an environment in which innovation is welcomed rather than clamped down on.
CEOs are political appointments because they get appointed by MECs, health MECs in provinces. Do we need to change the way in which we appoint them so that they have more appropriate skills?
Yes, definitely. I think they are more functional than political. Their role is to actually make these institutions work, and the particular environment of a rural hospital or a rural sub-district is that it depends on very few people. They are small and vulnerable systems, often isolated from one another. So they can succeed or fail on individuals who either make them work or not work. The government system is set up in a hierarchical way, and that does concentrate power and decision-making in very few people. There are other systems in which power is more equally shared.
Can you mention such an example?
The best example is Brazil, where the primary healthcare teams are paid on a capitation basis from Brasilia, from the federal government. And their success or failure is judged according to monitoring and evaluation data. And what they've managed to do is reorganize their primary healthcare system around what they call family health teams that really makes a difference. In this day and age, I always come back from Brazil inspired by the possibilities.
And what are the lessons we can learn from our ARV programs rollout?
It's very easy to run down the public health system and say, well, it doesn't work or it's collapsed. But actually, we have the most extraordinary large antiretroviral program, the biggest in the world, and it works. And the vast majority of people stay on their treatment. They know that it keeps them alive. So the nightmare of 20 years ago has disappeared.
Are there lessons to learn for the rollout of the NHI in what we did and how we did it with the ARV program?
The NHI is a much more complex system by comparison. The antiretroviral rollout was quite linear. The coming together of a public and a private system is a lot more complex than that. It involves quite a lot of other system issues and service delivery issues. And I must say that it is already happening in small pockets in this country. One of them is up in northern KwaZulu-Natal at Manguzi Hospital, where during COVID, for example, the patients could not come into the hospital, and specifically people with disabilities were not able to travel, and so they missed out on their appointments. The disability team at the hospital, that's the physiotherapists and occupational therapists, took the opportunity during the lockdown to go out into the community, and they visited every single disabled person that they knew of during those months of lockdown, which is an extraordinary thing. They've managed to document every single disabled person in that sub-district. That really makes a huge difference.
Steve, earlier in our program, we visited the Shawelo Community Practice Project in Soweto, and they've done similar mapping, and you also visited them a few years ago. Do you think they're a model which the NHI can use for rollout?
Absolutely. Chiawelo's one of my favorite examples, even in the craziness of an urban township setting. They've managed to show how care can be offered to a whole population, not just waiting for people to get sick enough to come in and see the nurse or the doctor. but proactively going out and creating a universal perspective of the need.
Thanks, Professor Reid, for your time and insights. That's our show. Until next time, remember, good health is the true measure of wealth.